Josephine H. Kaiser, in charge of training public health nurses in Okinawa, would repeat certain key advice to her public health nurses. You must have a spirit of dedication. You must be professionals. Use whatever appropriate skills and materials are available. Immediately after the Second World War, Okinawa was in an appalling state of devastation that is almost unimaginable when we look at the islands today. The social fabric was almost completely destroyed, and contagious diseases were rife. From the 1950s to the 1960s, tuberculosis, or TB, was highly prevalent and posed a serious health and social problem. However, the people had deep-seated prejudices about TB. Also, the measures available to deal with it were insufficient, and medical institutions were extremely inadequate. The main force for fighting TB in Okinawa was the system of public health centers and the public health nurses who lived throughout the islands, including outlying islands and remote areas of the main island. Specific measures for each stage of TB are important. Measures for preventing tuberculosis infection differ for the initial infection of an individual patient, for the progressive development of the disease in the patient, and for the period when the patient's disease becomes infectious. DOTS, Directory Observed Therapy Short Course, refers to the stage of treatment when patients are kept under direct observation while being treated with drugs. Although it is vital to make sure patients take their medicine in front of the nurses, the program actually involves a whole package of measures, including properly treating newly identified patients. Today's DOTS program includes 5 elements. Government takes leadership for TB control. Diagnose TB by bacterial examination and maintain observation of patients. Supervise patients taking the drugs. Provide the patients with the drugs regularly and adequately. Record and monitor the progress of treatment. More than 50 years ago, Okinawa developed and applied a program that had much in common with today's DOTS. This program was extremely effective in overcoming TB throughout the islands. Yaiko Nakada used to be a public health nurse on Miyako Island. Ms. Nakada treated patients in their homes. She now visits former patient Taro Uechi at his home on Irabu Island.
非常にお元気そうでよかったですね。
おかげさまで良くなって退院できたことは本当に皆さんのおかげだと思っております。
40 years ago, Ms. Nakada and the other nurses used to go by boat to Sarahama, the outlying island where we lived, and help us in many ways. They helped us in our family life and in how we related to our families. I listened to them and did just what they said.
Every month, we gave our patients enough drugs for the next month, so we had to check on how they were getting on. We visited them when their month's supply was used up. Our aim was not to check the drugs. We looked at the condition of the patient and checked to see how they were taking the medicine and whether it was in accordance with instructions. We would casually ask them to show us the bag containing the medicine and see whether they were taking the drugs or not. We just took a natural approach. Nothing very formal like the DOTS programs you hear about today. If they were not taking the medicine regularly, we asked them why they were not taking it and questions like that and gave them various kinds of advice. That's the way we did things in those days.
She was such a great person. Words just aren't enough. Yes, she was. Specifically, she saved my life. What was the role of the public health nurses in fighting TB? Let's look at what the public health nurses did at that time to understand the measures used to fight TB in Okinawa. The spread of TB in Okinawa was most virulent in the 1950s and 1960s. About 3,000 new cases of TB were recorded in Okinawa every year, with a morbidity rate of about 350 people per 100,000 population, a very high rate. So, after the public health centers were opened in 1951, the campaign against TB was seen as the main task of the public health nurses. The public health nurses stationed in every city, town, and village worked to prevent TB through those public health centers, with much work in patients' homes and communities. To prevent TB, it was first necessary to identify and register TB patients. The work of public health nurses started with finding TB patients.
Anyway, we were stationed in cities, towns, and villages for the first time. At that time, the local people had never heard of public health nurses. Naturally, hardly any patients or local people came to see us at first. So we went out to the villages ourselves to find people who looked as though they had TB. In my case, in particular, I went into school staff rooms and ate lunch with the teachers to get various information. Or I would ask the chief administrator of the area whether anyone had been absent from the village for a long time. I mainly collected information by talking with people. Where I was working, people were very concerned with TB prevention. The district welfare officer would tell me if there was a patient confined to bed and ask me to visit them. This is how I would find people who seemed to have TB.
When someone who appeared to be a possible TB patient was identified, a sample of that person's sputum would be brought back to the public health center, examined, and certified as negative or positive. How did the nurses living on outlying islands and in regions difficult to reach on the main island carry the sputum samples back to the public health center?
In the case of remote places where there were 1 or 2 buses a day, we asked the bus drivers to carry the samples back. The public health nurses would call the public health center, tell them what bus the sample was on, and ask them to meet that bus to pick up the sample. In the case of outlying islands, we asked boat captains to take the samples back. They would never ask for any payment. When a public health nurse and captain got to know each other, the captain would gladly carry samples back when the public health nurse asked.
If the sputum examination returned a positive result, the patient would have to be treated. However, streptomycin, the drug used to treat TB at the time, was very expensive. Most of the people were poor and struggled to live day by day. Patients who could not afford streptomycin could only be advised to get plenty of fresh air, bed rest, and good nutrition. These patients, whom the public health nurses had gone to the trouble of identifying, could not be treated. All the nurses could do was to try to prevent the TB spreading to the patients' families. To prevent contagion, any sputum brought up was to be wrapped in paper and burned. The public health nurses who had been taught this practice would ask the patients to do it, but some families did not even have paper.
At that time, there was a lot of canned food and things from America, so it was quite easy to get empty cans. I would use the empty cans for collecting sputum and bury the cans to stop the germs spreading. What I feared most was contagion. At home, people could try to prevent the spread of TB among family members by staggering sleeping positions so that heads and feet were alternated. Or if there was only one room, they could put up ropes and hang cloths or clothes from them to make separate spaces. This was about all they could do. In those days, the harder the public health nurses worked, the greater the trust that was built up between the patients and nurses. We wanted the patients to get well as quickly as possible. That was what all we public health nurses thought about.
The longer the search for patients went on, the more patients were identified. Eventually, the government was asked to devise a program to fight TB. In 1954, the Ryukyu Government enacted the Tuberculosis Prevention Temporary Outline as a means of stopping the spread of TB. With these temporary measures, a legal basis for measures to fight TB was established in Okinawa for the first time. The outline reflected the idea that the Ryukyu government should stand alongside the people of Okinawa to promote measures to fight TB. The Ryukyu government independently set up the temporary outline. We selected comparatively mild cases and treated them on a 6-month rotation system while they occupied beds at the hospitals. We told the local people that TB could be cured and that they must come to the public health centers for treatment. Even with the rotation system, there were not enough beds, so many missed out on treatment. So we had to do something about those people. Then Seigo Hanaki, a public health section manager, found out that the PAS, or para-amino-salicylic acid, and INA, isonicotinic acid hydrazide treatments got quite good results. So we took the decision to make home treatment using these drugs. Under the Tuberculosis Prevention Temporary Outline, a home treatment system started with public funding supplied through an Okinawa-style DOTS program. This brought hope to patients who had previously believed that TB was incurable and had given up. The public health nurses were stationed in the local communities. This enabled them to identify local people suffering from TB. But they couldn't just give out drugs and let the patients take care of things. They needed to manage patients' treatment. This was a vital part of the home care program. Managing the treatment effectively meant not only managing patient care, but also having an expenditure liability system in place for the public funds.
The temporary outline provided only a small amount of funding, so we couldn't supply all our patients with drugs. But because we wanted to give drugs to all our patients, the public health nurses would always attend the meetings held to decide which patients were to be treated at home. Even if there was a meeting on their day off, the public health nurses would give up their free time to attend it. And even if they'd just given birth, they would still attend those meetings to ensure their own patients were put on the home treatment program.
The temporary outline was carefully discussed by the public health center managers at all Okinawa public health center managers meetings. Then, each public health center manager would bring those details back to his own public health center and carefully explain them at staff meetings. Stationed public health nurses attended nurse section manager meetings where they discussed various matters. This participation ensured that the management systems were the same everywhere. This was the system under which the local nurses worked.
The public health nurses stationed in each city, town, and village worked closely together with the nursing section in each responsible public health center. We worked closely with the nursing section in everything, including monitoring the condition of patients and administration of drugs. The public health nurses received the drugs from the public health center, then delivered them once a month to their patients. Through this system, the relationship between public health nurses and patients became very close, and a feeling of mutual trust developed.
What was the status of the public health nurses at the time, given their major responsibilities under the Tuberculosis Prevention Temporary Outline?
The public health nurses were clinical nurses and so had a clinical nursing license and a public health nurse license. These national licenses gave them a recognized position in society. In their work, the public health nurses had to follow certain work standards. For example, in the case of TB patients in particular, when the patients spat blood, we had to give them a hemostatic injection or administer streptomycin, and there were work standards about medication. As for our wages, the Ryukyu government gave us various assurances or secured our status. The more remote the location, distant the island, or difficult the area we were sent to, the higher our allowances were. We had quite enough to live on.
The public health nurse's role in fighting TB was to identify potential TB patients, obtain sputum samples from them, prepare and store registers of TB patients and lists of patients approved for home treatment, record the movements of TB patients, create nursing records, make home visits, work with public health center doctors, welfare managers, and the private sector, treat, observe, and report on patients at home, and serve as advocates for patients and their families. Home visits involved helping patients approved for the home care program with their treatment and ensuring they were taking their medication properly. For patients who did not cooperate with their treatment, the nurses had to make frequent visits.
When public health nurses made home visits, they had to first of all take a look at the patient's whole lifestyle. Lifestyle could have a big impact on the effectiveness of the treatment. As side effects of the drugs, the patient could suffer loss of appetite or stomach pain. The public health nurses had to ask the patients whether they were experiencing such problems. The patients sometimes hesitated to say anything at first, but as they got used to the public health nurse, they often took the public health nurse into their confidence, for example, disclosing that the main source of the family's income had been lost and the family was struggling. When this happened, the public health nurse might suggest that the patient ask the welfare officer for help or suggest another course of action. In this way, the public health nurses and patients worked together to solve family problems.
The nurses took their responsibility to collaborate with doctors in the public health center seriously and worked closely with them. The doctors, for their part, used information and opinions from the public health nurses in their treatment policies and decisions. Whenever a local worker at a U.S. base was diagnosed with TB, that worker would be immediately fired from the base. The public health nurses would then explain the financial support available to the patient and introduce the patient to a welfare manager. If the public health nurses were unable to visit a patient at home, they would ask the chief administrator of the area to take the drugs to the patient. For patients on home treatment, the public health center managers would leave the administration of the drugs entirely to the nurses. The public health nurses would teach sanitation in classes for the local people. They would also work to increase rates of group health examinations.
We would seek the cooperation of the public servants at village, town, and city level and make our needs known to them. We would then take the official to the location where we needed his or her help. If there was an existing organization, for example, a women's group, a group formed by the area's chief administrator, or a youth group, we would offer to teach sanitation at the meetings of that group. When arranging such meetings, the most important thing was to select someone who had the trust and confidence of the local people. If the meeting was called by a person who had warm relations with the community, the meeting would be quite effective. At first, we would get a response of no more than 20% for immunization and group health examination programs, a very low rate, but this steadily rose. In my area, when we conducted TB surveys, for example, we got a 99% response rate.
To strengthen group health examinations, the Ryukyu government stationed mobile clinics at every public health center. In the group health examination programs, everyone tested underwent tuberculin reaction tests. In 1956, the tuberculosis prevention law was enacted by the Ryukyu government, and the tuberculosis prevention temporary outline was abolished. With the implementation of the Ryukyu Government tuberculosis prevention law, the Okinawa-style DOTS program was taken a step further. This made the activities of the public health nurses much easier. TB education could be based on the tuberculosis prevention law, and the problem of the cost of new cases in particular was eased. Everything was free, from first checks of new cases to treatment. Things were improved a lot.
When the tuberculosis prevention law was passed, all patients were registered and could receive home care. One purpose of the tuberculosis prevention law was to strengthen group health examination. This was now carried out everywhere in an effort to identify TB cases early. Villages, towns, and cities had health examination programs. Numbers of patients now suddenly increased as detected cases skyrocketed. Now the system changed from home visits to giving patients their drugs at local police stations. This was because of the large increase in patient numbers. There was simply no other way of coping. At that time, one public health nurse looked after 100 to 150 patients. Some public health nurses even had up to 200 patients. It was not possible to give each patient a daily ration of drugs every day, so patients in a stable condition were given enough drugs to last them a month. The public health centers sent the local police stations the amount of drugs requested by the public health nurses. This was often enough to keep all the patients supplied for a month and was sent by truck. These supplies were stored by the public health nurses. When a new patient arrived, the public health nurses would tell the patient how to take the drugs. The public health nurses created lists of patients and treatment schedules which could be read at a glance. The public health nurses could look at these and see when a patient had visited last and check whether the patient had taken their medicine over the last month. We were told that the TB drugs were expensive and like cash. When we gave out drugs, we had to get the patient's name, address, their signature on a receipt, and a certificate of their seal impression. When we gave drugs to patients, maybe 5 or 10 a day, we would receive drugs from the public health center. Every day, we would update our drug dispensing book, which showed the amount of drugs administered each day. A drug card for each individual patient, drug receipts, and the drug dispensing book were carefully kept at the local police stations. These were subject to accounts audits, along with the drugs kept at the police stations.
At that time, doctors, public health nurses, and patients would arrange appointments for the examination.
Appointments for the examination were necessary. For home treatment, patients had to take their drugs. But to see whether their condition had changed, they were x-rayed or their sputum was tested at the public health center. After the patient's examinations were complete, another appointment was necessary, and this was the follow-up examination appointment. At the public health center examinations, the physicians, doctors, public health nurses, and patients would talk about how the patients were getting on. The patients would often be encouraged to carry on fighting and to come back for their next test or observation of progress. In this way, doctors, public health nurses, and patient met together and checked for changes in the patient's condition. We visited each patient at least once a month to tell the patient how important it was to monitor the progress of the disease, to instruct the patient in treatment, and to see whether there were any side effects from the drugs.
The public health nurses monitored each patient, producing a monthly TB report based on their observations of the progress of the disease. If we look back on the home treatment system through contemporary eyes, it looks similar in some ways to the DOTS program. The patients were not given long hospital treatments. Rather, they were treated at home during the phase when the disease was not very contagious. but considering the situation in those days, there was probably little choice but to treat them at home. Group health examinations and TB treatment were all publicly funded. So how did the Ryukyu government raise that money? Of course, the main source of funding was taxes paid by the local people and also support from USCAR, the U.S. civil administration of the Ryukyu Islands. When the tuberculosis prevention law was enacted, support from USCAR fell, but we secured enough to keep the whole program going. By the 60s, the mortality rate for TB had fallen to 1/3 of the 1950s rate, but around 3,000 new cases were still recorded every year. TB was the main cause of death in Okinawa, and half of the patients were taken in their 20s and 30s, their prime years. Therefore, in the 1960s, the fight against TB had to continue to receive top priority. But the public health centers did not have many TB specialists. In the 1960s, though, Okinawa received good support from the mainland. A steady stream of specialists came over here from mainland Japan. These specialist doctors were posted to the public health centers and worked alongside us in fighting TB. As a result, the public health nurses could devote about 90% of their time to visiting TB patients at home. That was the situation in the 1960s. The results of home treatment were good, but because all TB treatment was free under the Ryukyu Government tuberculosis prevention law, more patients wanted to be hospitalized. However, in the 1960s, there were no more than 614 beds in the TB wards of public hospitals and sanatoriums. There was a severe shortage of beds for the estimated 10,000 TB patients. In 1955, doctors from the TB Prevention Association came to Goza Hospital to operate on TB patients. At that time, the most difficult thing for the public health nurses was patients who could not be operated on because they were in such a serious condition. We wondered what we could do for such patients. The public health nurses working with those patients tried to make a certain percentage of beds available to serious cases. But there were not enough resources to treat serious cases. So, the written opinions of the public health nurses on those cases played a very important role.
The public health nurses were very keen on getting their own patients into a hospital bed and would spend a lot of effort in writing reports for this purpose. The expressions they chose in those reports could sometimes be a little excessive in describing the grimness of the family situation and the condition of the patients.
At the TB conferences held to decide whether patients should be hospitalized, the public health nurses' reports could be quite emotional. Quite a few patients were admitted to hospital on the strength of heart-rending appeals by nurses. In 1962, to resolve the problem of too few beds, the Ryukyu government formed the agreement that Okinawa can send TB patients to the mainland of Japan for treatment, including surgery, with the Japanese government through USCAR. The result was to admit Okinawa TB patients to mainland sanatorium facilities and to treat and rehabilitate them there. It was the Okinawa TB Patient Society that actually arranged the hospitalization of Okinawa TB patients on the mainland. The Okinawa Medical Friendship Society was a group of TB patients formed in 1956 to secure patients' rights. These included the right to treatment and the right to be reintegrated into society. Because the Americans held political power in Okinawa, the Japanese government would gradually shut down any patients' rights groups that were formed. As a last resort, the members of the Okinawa Medical Friendship Society worked as individuals to send patients to Japan. Patients were sent from Okinawa at the decision of High Commissioner Caraway. In this way, a three-way Japan-U.S. Ryukyu agreement was formed to solve the TB problem. Then, on June 30th, 1962, 100 TB patients were officially sent to Japan for the first time. This was one step towards sending patients to Japan for treatment. Specialist physicians at the public health centers, hospitals, and sanatoriums decided which patients would be treated in Japan. The public health nurses worked energetically so that more of their patients could be accepted at mainland hospitals.
The public health nurses were naturally overjoyed when their patients were accepted, but also often very sad to see them go. The public health nurses knew the most about their patient's situation, about their families, finances, and the needs of the patient. So in their role as public health nurses, they could talk to the doctors and help them make a decision. For example, they might point out that although a patient needed treatment, her children were still too young to be left without her, so it would not be appropriate to send her to Japan. Or if the patient was the family's breadwinner, that the family would suffer if they lost that income, and the patient would worry about how the family would cope. In this way, the public health nurse would inform the doctor about the wider interests of the patient. The public health nurse in her capacity and the doctor in his would spend some time in deciding whether the patient should be sent away for treatment or not.
By the time Okinawa reverted to Japan in 1972, around 2,700 TB patients had been sent to Japan for treatment under the system.
Although the patients were hospitalized on the mainland, they remained our patients. When they were gone, we still had to keep an eye on their families who were left behind. If there was any information from the mainland or the hospital, we would inform the families immediately. Usually we would tell them that the patient was well and in good spirits. But sometimes we also had the very unpleasant task of telling families that a patient had died or was not progressing well.
After peaking in the 1960s, TB in Okinawa began to decline. What were the reasons that the fight against TB in Okinawa succeeded so well? What I would particularly like to emphasize is that public health nurses working mainly through the public health centers were distributed all over Okinawa. They were posted everywhere, including on outlying islands. This boosted the whole fight against TB. A sense of fairness was also developed by the public health nurses being posted all through the islands. It was important that the local people, the public health center staff, and the Ryukyu Government, the administrative authority at the time, all shared a common purpose in making the fight against TB the top priority. In addition to doctors and public health nurses, the public health centers were also staffed by clinical laboratory technicians and radiologists. The fight against TB was based on public health centers as the organizational units where the technical staff were stationed. From the identification of patients to treatment and registration of patients, everything was based on the public health center system. This was a major factor in the success of the fight against TB in Okinawa.
Our success was due to our training by Josephine Kaiser. Public health nurses were stationed in villages, towns, and cities, and each worked by herself in instructing the local people in public health. However, Ms. Kaiser used to tell us, the leaders in public health are you public health nurses. I believe that this training by Ms. Kaiser is the reason we succeeded in fighting TB.
The fight against TB, based around the public health nurses, shared the same elements as the World Health Organization's DOTS program. The DOTS approach has sought to bring services into every corner of the community. However, the Okinawa DOTS program even exceeded this in one aspect. That is, while being deeply involved in treating patients in the community, the public health nurses used the local administration to the fullest. made the local administration work to fight TB and carried out the TB campaign from a position somewhere between the local authorities and the local people. The vital message of the WHO-promoted DOTS program lay in the commitment of the government and local administration, but the main message of the Okinawa-style DOTS was that the health workers on the spot had authority and responsibility and worked willingly and independently. The know-how in the fight against TB was later used to fight contagious diseases such as malaria and filariasis. Public health nurses played leading roles in those too. At that time, I thought I was going to die. Now I have 10 grandchildren, and I'm very happy.
Now I am so happy. When I talk about that time, I can't help crying.
At that time, our wives were busy building a wharf down at the bay.
The patients worried about their families, and I believe this was what helped pull them through. I now encourage people to become public health nurses, telling them that a public health nurse is the best job. When you think of what you are doing, you are making people happy, and this gives you a sense of satisfaction. You are serving other people.
The public health nurses carried the brunt of the home treatment system, also known as the Okinawa-style DOTS program, and achieved remarkable results. Their fight against TB, the greatest achievement of the public health nurses, laid the foundation of public health in Okinawa.